Good morning, all. Today I am going to discuss the pulseless electrical activity. So, the heart electrical activity is there, but there is no pulse. That means the heart unable to produce the cardiac output that to generate the pulse. So, heart is contracting, electrical activity is there, but there is no cardiac output. So, different conditions that will cause the pulseless electrical activity. And pulseless electrical activity, you can see the CCLS guidelines regarding IRC of algorithm. It will come whenever you apply the AED. AED will analyze the pulse, the shockable or non-shockable. So non-shockable rhythms, there are two rhythms are there. One is a pulseless electrical activity, second is the asystole. So the pulseless electrical activity is very difficult to treat, and you have to do a lot of things to recover the pulseless electrical activity. Myself, I am Dr. Srinivas Rao Surseti, Associate Professor of Anesthesia, SV Medical College, SVRRGH, Tirupati. So what are the today's objectives are? So we have to know the etiology of pulseless electrical activity, and we have to know the pathophysiology of the pulseless electrical activity, and we have to diagnose and management of the pulseless electrical activity, and the interpersonal team efforts are more important in the successful resuscitation of a patient with a pulseless electrical activity. So how they will work, who are the members they are in the team, that should be, we will discuss later. So coming to the definition of the pulseless electrical activity, this is the electromechanical dissociation. So electromechanical dissociation. So electromechanical thing is an electrical thing, electrical activity, it follows, it causes the contraction. There is a mechanical thing of the heart that will create the cardiac output. But here what happens is electromechanical dissociation due to the various reasons. It causes a clinical condition characterized by the unresponsiveness and impalpable pulse. So there is no pulse to palpate in the presence of sufficient electrical discharge. So electrical activity is pertinent, but it is not sufficient to cause a condition for contraction. The word sufficient is being used here is to describe a degree of ventricular mechanical activity that is adequate to generate a palpable pulse. So there are two types of pulseless electrical activity. One is a pseudo pulseless electrical activity. Second is a true pulseless electrical activity. So pseudo pulseless electrical activity, the pulseless activity does not necessarily mean the lack of mechanical activity. So mechanical activity is there. There can be ventricular contractions and detectable pressures in the aorta, but we cannot palpate the pulse here, which are known as a pseudo pulseless electrical activity. But true pulseless activity, it means is a state in which cardiac contractions are lacking. In pseudo, some contractions are there, but they are unable to create the pulse, unable to produce the pulse. But here, there are no cardiac contractions. The cardiac contractions are lacking in the presence of coordinated electrical impulses. Electrical impulses are coordinated. You can see in the ECG, you can see all the waves like a PQ, RST waves, everything will be seen in the ECG that will create the coordinated electrical impulses, but the cardiac contractions are lacking. But one thing you should be very, very cautious whenever the PEA is diagnosing. An impalpable pulse should not always be taken as a pulseless electrical activity because it may be due to the severe peripheral vascular abnormality. That's why you have to palpate the 2 or 3 or 4 reasons to decide the pulseless electrical activity. Because the peripheral vascular abnormalities are more common, especially in the old age people. So due to the vascular thickening and vascular obstruction, there is no pulse will be there to distill the obstruction. That's why you should be very cautious when you are diagnosing the pulseless activity, especially in the old age people. So let's come to the etiology. Etiology is the primary causes and secondary causes. Primary causes are exclusive for the cardiac causes. Secondary causes, that is the non-cardiac causes that will cause pulseless electrical activity. This primary pulseless electrical activity often caused by or related to the cardiac arrest due to the depletion of myocardial energy reserves. So it responds poorly to the therapy. So causes secondary pulseless activity include the famous 6 H's and 6 T's. You can see here hyperkalemia, hypoxia, hypothermia, hydrogenase, hypovolemia, hypoglycemia, tamponade, tension pneumothorax, thrombosis of that is pulmonary embolism, myocardial infarction, toxins and trauma. All these conditions they will cause the stoppage of the cardiac contraction or decrease of the cardiac contraction. You can remember like a mnemonic, like a hit the target, where we can discuss in our CCLS guidelines. Okay. So what these are all the things, they will all the these reversible causes, they will decrease the cardiac contractility. But electrical activity is there, they will decrease the cardiac contractility so that the heart cannot produce adequate cardiac output or adequate output that create the pulse. So if you treat all the reasons, the pulsal activity, you can treat it easily. So come to the epidemiology, the incidence of pulse activity varies among the United States and different major populations. It occurs approximately 20% of sudden cardiac deaths outside the hospital settings. So a study found that 68% of the recorded in hospital deaths, 10% of all in hospitals were attributed to the pulsal electrical activity. In addition, hospitalized patients are more likely to have a pulmonary embolism among the other complications. This pulsal electrical activity is the first documented rhythm in 30 to 38% of the adults with in-hospital cardiac arrest. And moreover, the beta blockers and calcium channel blockers may alter the contractility, leading to the increased susceptibility and resistance to the treatment. And you can see the women are more likely to develop pulsal activity as compared to the male population. The risk of pulsal activity increases over as the age progresses, the age of 70, especially in the female population. So let's come to the pathophysiology. This PEA occurs in insult involving the cardiovascular system, GAT, and respiratory system. These systems insults results in the inability of the cardiac muscle to generate the adequate force in response to the electrical depolarization. These adverse events decrease the cardiac contractility, and the situation gets severe by potential acidosis and hypoxemia and worsening of the vagal tone. So more compromise of the inotropic state. So inotropic state will be more compromised then leads to the insufficient mechanical activity despite the presence of electrical activity. So inotropic state of the cardiac muscle will be compromised. It causes the degeneration of the cardiac rhythm, eventually death follows. Respiratory failure leading to hypoxia is one of the most common cause of PEA, responsible about half of the PEA cases. The following are other mechanisms for the pulsal activity, that is a decreased preload and increased afterload and decreased contractility. So decreased cardiac contractility has been related to change in intracellular calcium level, which explains why the patients with the beta blockers or calcium channel blockers they are more prone for developing the pulsal selective activity and may become unresponsive to the treatment. You can see the acute coronary syndromes that finally it leads to ventricular fibrillation. Before ventricular fibrillation, pre-occlusion of severe left ventricular dysfunction causes acute pump failure that goes to the pulsal activity. After that, it goes to the ventricular fibrillation. This PE and right ventricular failure, what happens? Especially in case of pulmonary embolism, ARDS and mucus plug obstruction and massive aspiration and hypoxic respiratory failures. What happens? Elevated pulmonary pressure will occur. Whenever the elevated pulmonary pressure occurs, right ventricular overload or dilatation causes right ventricular ischemia and conduction delay occurs. Contraction will decreases. So right ventricular failure. Finally, patient may land into the pulseless electrical activity. Coming to the while examining the patient of pulsal activity, we have to take the history and physical examination. A thorough quick history is very important. Risk of any myocardial infarction or pulmonary embolism, any risk of trauma, any severe blood loss, fluid loss, and exposed to the low temperatures or risk of metabolic derangements, and you have to physical findings. The name indicates the absence of pulse is the foremost finding. And depending upon cause, one of the physical signs can see in tracheal deviation. If you see the massive pneumothorax, tracheal will be deviated to the opposite side. Decreased skin turgor, that is a severe hypovolemic cases, decreased skin turgor occurs. Traumatic chest, you can find any cardiac component, and cool extremity with hypothermia and tachycardia, cyanosis. These are all the different signs you can find in a pulsal selective artery patients. So how to evaluate? We have to evaluate the PEA by giving the electrocardiogram and ABG analysis and serum electrolytes and core body temperature and chest X-ray and echocardiogram and ultrasound. So this is a CCLS where you can see here where whenever this is a Here, when if you attach the AED will analyze rhythm, shockable or non-shockable. Here in non-shockable, two rhythms are there. One is the pulseless electric activity and second is the asystole. So if the patient is non-shockable rhythm, you should not give the shock and you have to treat the reversible causes along with the chest compressions. What are the reversible causes? Already previously described the hypoxia, increased cardiac hydrogens and the acidosis, tension pneumothorax and toxins and poisons, and hypovolemia and hyperkalemias and cardiac tamponades and acute coronary syndrome and raised intraocular pressure like subarachnoid hemorrhage and hyperglycemias and embolisms and temperatures. These are all the things you have to correct along with the CPR. So management comes first. You have to continue the CPR. After continuing the CPR, you have to continue the 5 cycles of CPR. You have to give the 1 milligram of epinephrine. 1 milligram even given every 3 to 5 minutes. If there is a bradycardia along with hypotension, you have to give the injection atropine 1 milligram every 3 to 5 minutes. If there is severe acidosis you are suspecting, then you have to give the injection soda bicarb. And if you see any reasons like after taking the investigations, any finding the pericardial tamponade and severe pneumothorax, you have to thoracotomy and pericarditis sepsis, and you have to reverse the reversible causes. So let's come to the man. And the first step is you have to begin the compressions according to the comprehensive cardiac life support protocol. Follow the administration of epinephrine every 3 to 5 minutes while simultaneously looking any reversible cause. Once the diagnosis is made, you have to do the specific management to the diagnosis. Very severe pneumothorax, decompression of the pneumothorax, if any cardiac tamponade, pericardial cardiac tamponade, then severe hypovolemia, fluid infusion, you have the correction of body temperature for hypothermia, and you have to administrate of thrombolytics, that is myocardial infarction or pulmonary embolism, and ABG and serial meter should be applied during the resuscitation process to correct the other things. So coming to the epinephrine should be administered 1 milligram doses intravenously every 3 to 5 minutes during pulseless electrical activity. Each dose should be followed by the 20 ml of flush and elevating the arm for 10 to 20 seconds for better perfusion. Higher dose of epinephrine have not been shown to improve the severe neurologic outcome in most patients, but in selected patients like those patients are in a beta blockers and calcium channel block overdose. So this higher dose of epinephrine may benefit in some situations. So it can also, if the IV or IVAX are not available, the epinephrine can also be given endotracheal tube 2 milligrams in a 10 ml of normal saline. But usually now avoiding this endotracheal intubation, but better to use an IV or IVAX are better if you want to give epinephrine. So atropine, if detected rhythm is bradycardia, that is also the hypotension, then atropine 1 milligram every 3 to 5 minutes, up to 3 doses should be administered. That is considered the optimal dose. Beyond, with no further benefit occurs. So note that atropine may cause pupil dilation. Therefore, the sign cannot be used to assess a neurological function whenever you are examining a PA case. Coming to the sodium bicarbonate may be used in patients with severe systemic acidosis. The pH is less than 2.5 like that, and hyperkalemia and tricarboxylic acid overdose. In such situations, only can use sodium bicarbonate, but dose of the sodium bicarbonate is 1 milliequivalent per kg. And avoid the routine admission of sodium because it worsens intracellular and intracellular acidosis without affecting the mortality. And pericardial drainage and emergency surgery may be life-saving in appropriate patient the pulsal activity. In patient with a refractory case and chest trauma, thoracotomy may be performed immediately. And a near pulsal electric activity, a very low output state may also be managed with some mechanical devices with circulator for circulatory assistance, that is IABP, intra-aortic balloon pumps, and ECMB, extracorporeal membrane oxygenation, and cardiopulmonary bypass and ventricular assist device. They can be used to increase the cardiac output. So the chance of successful outcome depends upon a very coordinated and resuscitation process. So there should be a specific person responsible for the specific steps and a good team leader. So differential diagnosis, there are the number of different diagnoses for PEA, the accelerated atrial rhythm, acidosis, cardiac tamponade, drug overdose, hypokalemia, hypothermia, hypovolemia, hypoxemia, myocardial pulmonary embolism, syncope, and tension pneumothorax, and ventricular fibrin. There are all the different diagnoses for the. These are all the reasons for the PEA activity. So if you correct all the reasons, automatically the corrected thing will be corrected. So prognosis, patient have sudden cardiac activity, pulsal activity, they have a poor outcome. In one study published in European Journal of Trauma and Emergency Surgery, 150 such patients, 23% were resuscitated and survival until hospital administration, but only 11% survival until the hospital discharge. Unfortunately, despite optimum cardiopulmonary resuscitation, pulsal activity still carries a high mortality rate. So different consultation, different medical personnel may be necessity to do the pulseless cardiac, pulseless electrical activity. So what are usually the patients are sent to the intensive care unit. The intensivist has to be there, and vascular surgeon if any large embolus is detected, and toxicologist is suspected poisoning is suspected, and the cardiothoracic surgeon for a cardiac tamper and a cardiologist myocardial infarction. Well, different. This is not a single man show. So this is a teamwork. So according to the diagnosis, according to the etiology, we have to take the help of other consultants. So take-home message is pulsal activity is a significant cause of mortality, especially in hospitals and elderly patients. Immediate evaluation for the cause is warranted, and good quality cardiopulmonary bypass is the first step after the activation of the emergency response system. And epinephrine should be used in conjunction with the cardiopulmonary resuscitation. The foremost priority is the hemodynamic stability of the patient. So you have to maintain the hemodynamic stability by reversing all reversible causes. So automatically the survivability increases. So a 6% high performance cardiac arrest team is the best to manage the pulsar electrical activity. Thank you.